So over the last decades, we've learned that actually it's not only an LDL disease, but atherosclerosis is combined by LDL and inflammation. Now, what drives inflammation in atherosclerosis and what dictates the level of inflammation? Actually, very little is known. We have learned, however, that CRP is only a marker and not causally involved in atherosclerosis, and that cellular inflammation, so monocytes, T cells, they dictate the fate of the vessel wall inflammation, which creates actually CV event rate. So I presented some data to actually show that if you take, for instance, monocytes, who are considered not to have a memory, being part of innate immune system, that monocytes actually do have a memory. How can this be? Monocytes having the capacity to learn from inflammatory reactions. Well, there it's very interesting that the first data seem to imply that atherosclerotic risk factors actually have an epigenetic impact on cellular inflammatory cells. So without changing the DNA, epigenetic modulation of histones leads to a continuous hyperactivity of these circulating inflammatory cells. And that is the beginning of an exciting journey where we're going to learn whether we can modulate epigenetic regulation of cellular inflammation in atherosclerotic patients, which may eventually lead to less inflammatory activity and therefore more stabilization of atherosclerotic lesions in high-risk cardiovascular disease patients. We discussed in familial hypercholesterolemia that FH patients are characterized by very high LDL levels. Now, we've learned in a lot of cardiovascular intervention trials that the lower the LDL, the lower the risk. Now, first that was in statin trials, the TNT, the IDEAL, but now recently the IMPROVE-IT trial giving ezetimibe on top of statins also showed that lowering LDL by ezetimibe, cholesterol absorption inhibition, also reduces cardiovascular risk. So this gives a new dimension that lowering LDL lowers risk, but it doesn't really matter how you lower LDL, at least statins and cholesterol absorption inhibition both lower LDL and lower risk. Now the next question is, what is going to be the next step, because there's still a residual risk in these patients? Well, here now we will shortly, at the end of this year, expected, get the data from the PCSK9 antibody study. So that's the first one will be the Fourier study, most hopefully at the American Heart Association, which will show whether a reduction from 90 milligram per deciliter to an envisioned maybe even 40 milligram per deciliter will result in a reduction of risk. And if so, we finally may have resolved the LDL burden, the LDL contribution to risk, because we can now in very high risk patients lower LDL to levels where no one's ever been before. We look forward to the data.